Good day, all, and welcome to the Telemedicine Pulse podcast, your Rural Health Matters resource. Hear from your colleagues and industry experts on rural health issues and innovative care models that make a difference for rural hospitals, providers, and communities.
Hello and welcome to the Telemedicine Pulse. Shane, we've got another great guest with us today. I think he's got some interesting things to say about virtual care and how it's just becoming everyday care now.
Oh, Andy, we're honored and blessed to have Ivan Mitchell, the CEO of Great Plains Health out in North Platte, Nebraska, with us today. And it's really just an honor to have you, Ivan. And incidentally, you showing up in a tie and unfortunately, and when I first saw you showing up to the podcast to do this, I thought you wore the tie for us. As it turns out, you're going to a fancy meeting afterwards. So it just happens to be coincidence. But nonetheless, it's great to have you on the podcast and you spending some time with us today. Really appreciate that. You're a seasoned veteran at these sorts of things in virtual care and been a leader and a pioneer in this space for years. And Great Plains being a partner of ours, for over 7 years now, has been a spectacular relationship. And we're honored that you're here to spend some of your valuable time with us to share your message and share a little bit about Great Plains Health and all the great things you're doing out there in Western Nebraska. And I think what we'll do, Ivan, to start is maybe just start by introducing yourself, and then we'll kick things off.
You bet. Thank you, Shane. Yeah, we typically don't wear ties out here in Western Nebraska, but I will for you if you want me to. But yes, we have a board meeting retreat today, so getting ready for that. But yeah, I mean we've been it's wonderful. Great Plains Health. We're out in West Central Nebraska, 116 bed hospital. We're, I guess, what you would call the big hospital for kind of this. It's about a fifth of the state. We do cover into Northwest Kansas, Northeast Colorado. Get patients from southwest part of South Dakota. So we do cover a large area. 116 beds doesn't sound like a huge hospital, and it's really not. But we do some really high end work. We have neurosurgery, interventional cardiology, and of course, kind of your core service lines: orthopedics, oncology, cardiology. It's a great place to be in practice, independent nonprofit community hospital, and so all the everything that's left over at the end of the day comes back into our community. And yeah, we've been a virtual care partner for a long time, even years before the pandemic. So I think we were partners with Shane and Telemedicine Health. We've probably one of the organizations that was maybe on the cutting edge of implementing telemedicine. So it's fun to kind of reflect on what we've done over the years.
I think back, Ivan, to the first conversations that you and I had going back, probably 8 years ago. And it's always, by the way, Great Plains does amazing things out there, and the team and the staff are amazing. It's beautiful out there as well. So it's a fantastic place to be and work. And I know the conversations that you and I have had going back 8 years ago, I always respected you and your vision and your appetite to really investigate different types of unique and cutting-edge strategies to help keep patients closer to home and help provide more services to the community. And you guys have really knocked it out of the park. So I'm excited to share your story today on that front. And I know that early on, pulmonary critical care was one of the early programs that we put together collaboratively for you guys out there. We'll talk more about that in depth as well as inpatient nephrology and dialysis management, infectious disease and pathology, which was kind of a unique offering that didn't exist really before we brought that to the table based on a simple phone call from you that said, hey, by the way, what do you think about this? And that morphed. And then also helping Great Plains move some of their subspecialties that have bandwidth out into the rural communities in and around North Platte and the Great Plains area. So it's been a great relationship. And I think, you kind of already given a little bit of an overview of Great Plains Health, but I wonder about a snapshot, Ivan, or your perspective, if you sort of reflect back 8 years ago and what you were thinking in your vision around this and the partnership around this, as you're pondering what types of virtual strategies to put together, as you kind of walk us through your journey, as you reflect back and to take this as an opportunity to kind of reflect on all the great things you've accomplished out there.
Yeah, no, thank you. It was really fun to piece together. Shane and I, we were having a conversation a couple of years ago after the pandemic, and I kind of asked you, what was business-like. And you said that, prior to the pandemic, it was like we were trying to push a boulder up a hill and try to get people on board. And then after that, you're on the other side of the hill and you're trying to catch up with the boulder kind of rolling down. So it was pretty fun when we were talking about these ideas and people were looking at us like we were nuts. That was actually kind of a fun time, yeah. So I think, out of necessity, I ran a small critical access hospital in North Dakota before coming to the big city of North Platte. But the demographics are pretty clear. There's a severe physician shortage, and it's difficult to recruit to rural areas. And so, a couple of different thoughts were in there. Number one is we would get some great physicians that would come and join us here at our organization. And one of the challenges that we have is we'll say, okay, here's the only amount of call that you're required to take. But if there's only one or two physicians in that practice, they care about their patients, they care about their community, and a lot of the time they will get, a quick phone call here and there when they're not on call. And eventually that leads to burnout, and then they're going to go join a group in a big city where there's 8, 9, or 10 of them, and they're not on call as much. And so, our county's about 40,000, but we cover, the area that we cover has about 90,000 people in it. And so, pulmonology, for example, we need one full-time pulmonologist here for sure. Probably 1.5 or 2 would probably fit the need. But if you're a physician and you're getting two, 3 calls a day, they say the average one gets 2 or 3 job inquiries a day. Do you really want to be somewhere where you're on call 24/7, 365, even when you're not? Because we know how it works, you kind of are. And so that was the thought process. And then also, it seemed like there were, we have a good hospitalist program. It seemed like there were a lot of patients that were kind of on the brink of, I'm not sure whether I need, a pulmonology consult with this or not. I'm not sure whether I need a neurology consult with this or not, or an infectious disease consult or not. And so a lot of those would just get transferred out. And honestly, with a quick phone call, an analysis of the chart, maybe a quick visual exam, just having that specialist say, hey, this patient's fine to stay there. Here's what you need to do. If things escalate and they get worse, then transfer. But just giving a hospitalist some of that guidance with some of these specialties was able to keep more patients here. So ideally, number one, we're trying to make a good work-life balance for our current doctors, and then 2, being able to have just some of that oversight for some of the transfers that maybe don't need to go to the bigger city. Can we, with a little bit of encouragement and advice, can we keep them in our community? And so those were kind of the areas that we were looking at, and probably we'll talk about this a little bit later, but in some of these services that we were trying to grow, we would augment the staff with locum physician costs, and those are not sustainable for a small organization. So really looking at the areas where we're utilizing a lot of locum physician services and seeing if there is the ability to augment that with virtual services and avoid that the boots on the ground locum costs are just not, they're not going to be sustainable. They can fill a gap here and there for a week, but if that's something that it looks like it's going to be a consistent expense for your organization is not going to be around if you don't figure out how to maintain that.
That's huge. And I think so. 2 things I want to circle back on. We're going to circle back on that for sure. But prior to that, I remember a conversation that was probably 8 years ago or thereabouts, and Great Plains was in the midst of trying to recruit a pulmonologist there, and I was really struggling with trying to elicit a physician that was willing. To your point, listen, we're going to recruit you here. And I tell you what, you're only going to be on call 10 days a month, and don't worry, we won't call you the other 20 days, even though you're the only show in town. And they're like, yeah, right, man. That's not going to fly. I mean, come on, you're not going to do that. And in some cases, the provider doesn't want to do that either, right? I mean, they have their patients, they get attached to their patients, and it's tough when they're sitting at home or somewhere else, and their patient needs a pulmonary physician or a critical care physician, and there's nobody available, and so they just have to transfer. So there is a component of guilt with that too. And the conversation was around, golly, what if we start the 24/7, 365 pulmonary critical care strategy and use that as a recruitment tool to an individual to say, listen, you come work for us and we're going to cover you virtually, the other 20 days a month or the other 15, whatever it ends up being. And man, it really worked well. And in fact, I don't remember the exact timeline on when the pulmonary physician was officially hired at Great Plains, but it was 6-ish months later, roughly thereabouts, and he's still there. And how long ago's that been? That's been several years ago, right?
Yeah, I mean, I'm guessing we're probably 6-7 years in. A lot of the recruits that we get in these specialties are J1 waiver physicians. Because we're a rural area, we were able to recruit so many J1 waivers, which is a foreign trained physician who does a residency fellowship in the United States, and then they commit to about 3 years. And a lot of times after they get their green card, they'll go somewhere else. But this Dr. Molina, he'd be a good one for a future podcast here. Just a great personality, great guy. And he comes here. Young family, couple of young kids, and they have just really integrated well in the community, have a lot of friends, and because of the support that we have with virtual telehealth, I think he sees this as a place where he could stay for his career. And so big win. I know that as I talk with the group that supports us virtually, like Dr. Martin and others, they just have a lot of respect for Dr. Molina, and it's almost like they're part of the group together. It's a great relationship.
Really is. And the other thing is it really gives, that physician who's coming in, especially if they're fairly new or maybe they're just out of residency and they really don't know. I mean, they think they know, right? They think they know, I want to do X, Y, and Z on the outpatient side, or I want to do X, Y, and Z on the inpatient side. I want to do this in the ICU or this level of critical care. And then over a year or two between the call and the balance, and they sort of gravitate to one area that they really enjoy. And, this type of program really gives them the flexibility on that front if they want to focus a little bit more on the outpatient and clinic side of the equation. It gives us some flexibility to do that versus, all the onus that goes along with inpatient types of care. So no, that's great. And by the way, Dr. Molina is awesome, and Dr. Martin and the team loves him, and the relationship is completely collaborative and wonderful. They've done amazing things out there. I'm going to touch on another thing you brought up, Ivan, in terms of the locums coverage. I can't agree more in terms of those fees, but a question I do have for you on that front, aside from the fees and the inordinate expense associated with that type of program, particularly if it's an ongoing thing, as you mentioned, what about, from your experience, one of the things we hear from a lot of the hospitals that bring in locums and a lot of variability in the locums coverage, we really do see hospitals that struggle with continuity. They struggle with consistency. They struggle with providers developing relationships with. And as you reflect back on the pulmonary program, for example, and albeit virtual teams, but the team's been there for 7 years. I mean, they know each other very well. They know the nursing staff. They know the physician. They know Dr. Molina, the ID team, the nephrology team, same thing. Versus if you think back, well, if we were replacing that nephrologist, maybe it's boots on the ground, but every other month it's a new person or a new individual, so you have the expense and the continuity. Can you kind of speak to that continuity and consistency and relationship part?
Yeah, and I'm glad you're hitting on that. That in many ways is even more important than the expense side of things. But in my experience, when you're dealing with a locum or a traveler, whether this be nursing or whether this be physician locum services, 10 to 20%, you might find a free spirit who is just an exceptional physician or nurse that likes kind of bouncing around to new places. But a lot of them are people who maybe have a tough time being somewhere or struggling, or they struggle kind of being in a place consistently. And so, we use Dr. Martin's name, who kind of helped lead the virtual care push on pulmonology. You're not going to find a Dr. Ryan Martin doing locums coverage. I mean, he's just top-notch doctor. And So the ability to bring in, kind of a high-end team, high quality, great personalities, good bedside manner, good people skills, and then have that continuity of care where Dr. Molina knows how they're going to practice, they know how Dr. Molina is going to practice, and that is just very helpful versus bringing in a unknown locum. You look at the resume and basically bring them in, and sometimes every once in a while you do well and you get someone that does a really good job that's maybe in between jobs or something like that. But a lot of the time you're not getting the quality that you hope to find in a physician provider or even a nurse in the travel nurse side. So especially when you're putting together plans of care for patients that are probably going to be, if they're intubated, they're probably going to be in the hospital a little bit longer than usual. And so having continuity of care, having a team that works together, that knows each other, that understands the capabilities of your facility, it's hard to quantify the monetary value of that.
I'll completely agree. In fact, we've been trying to do that for some time because it's such a huge. I talk about this frequently in strategy sessions with hospitals around recruitment and retention and consistency and continuity and overall quality. And it's hard. Just those areas are relatively hard to quantify in a lot of cases what these programs can do for you. But boy, especially in these programs that the volumes are relatively steady and in some cases busy. Boy, the continuity is so important, and we've seen these programs just flourish where the relationships just improve daily, and then they know what each other's doing, what they're thinking, what to expect coming into the facility. Oh, Dr. Fiedler was on, or Dr. Martin was on, or Dr. Jarrett was on, and before you know it, they already know. It's very consistent as a group strategy, and so from a protocol perspective, if there's questions, Dr. Molina and Dr. Martin will get together and talk through that and just discuss what should we be doing on this front? What are you guys doing? What are you seeing in the other facilities? It's just very collegial in how that comes together. So,
the nursing staff builds relationships with every one of those virtual care providers too.
They do, and I think Ivan, from your perspective, which is another piece in here, in terms of the nursing side of the equation, which we've been focused a little bit on the physicians here, but let's shift gears a little bit to the nursing side of the equation. And what have you heard from the nurses? Now, granted, you have, Chastity really helps sort of spearhead the virtual care programs. But from a nursing perspective, bedside nursing perspective, what do you see and hear from them over the last 7-8 years as part of these, being involved in these types of programs?
Yeah, it has been a very positive experience for them. And for example, if you have one specialist and, there comes a point where they almost feel bad. They know they worked a full day in the clinic, they've done their rounds in the morning, and then as they left, sometimes the nurse kind of feels bad about calling them after hours. And so, having someone assigned that their job is, the telemedicine, I think there's, if they really do need some help, there's a feeling that they're maybe backed up a little bit more. They're not inconveniencing as much. So I think that works well for them. And, one of the major successes of our program was Chastity, who we brought in as kind of the lead nurse to help implement our telemedicine program. And having a kind of a nurse help lead that and walk the bedside nurses through how this is going to work, showing them best practices and whatnot. I think it really helped our program succeed early on, and it helped other programs grow because, each time we implemented something, we were successful. We saw the benefits of it, and we were able to kind of work through some of the issues quickly by having Chastity help with that.
Yeah, and from our perspective, she's been great to work with.
Yeah. It's always helpful. Again, I've said this, I don't know how many thousands of times on all these programs, but the nurses are really the linchpin at the bedside in these acute care programs. If you don't have nursing buy-in, you don't have nursing support as part of this, they're really difficult to move this forward. And there's several components that lead to nursing satisfaction with these programs. But one of the things that does lead to nursing satisfaction is certainly the physician continuity and the physician consistency and the relationships coming from the providers as a main pillar in that category. And then folks like Chastity who are there as a local resource to really help sort of lead the way. And if they have questions or concerns, can circle back with her. And you guys have done also some fantastic work. Part of our launch process includes, educating the nurse leadership on what to consider for new hires and what to consider for nursing ongoing orientation or nursing skills days, or there's a variety of different things that facilities call that. But at the end, when they have their annual competency days, skills days, whatever they're calling it, to have a component of virtual care in there on what they're doing, what they're up to. Here's how the technology works, just a refresher. So, and you guys have really done such a great job. Chastity's done a fantastic job on that front, for sure.
Yeah, we've had multiple skills days where we've had virtual care being part of that.
Yeah, no, that's it shows. I mean, listen, your programs they always go very well and very well received, and it's just been a great relationship on that front. Let's shift gears to a little bit from what your perspective would be on the hospitalist side of the equation, what their feedback has been, or the emergency department providers in terms of the ability to access these types of resources.
Yeah, we've had good response from our ER docs and our hospitalists, and I mean, they would tell you that ideally they would like to put in a consult and have someone come walk in and take care of the patient, and I think that that would obviously be the preference for everyone, but kind of in a lot of these rural areas, and so us being kind of the big hospital for this region, if we can't care for people here, they're being transferred over 100 plus miles to the next facility that maybe has some specialists that we don't or whatnot, and that's a burden on the family to go visit their loved one. And so for us, we have board certified ER physicians, but again, you kind of get that person. Okay, does this person need to be transferred or do they not need to be transferred? And just being able to connect with a specialist and talk through whether this patient really needs to be transferred or not it's a big deal for them. Along with that, we don't have, as we have one pulmonologist, we don't have a critical care physician rounding on all of our inpatients every day and being kind of the primary caregiver for them. They're internal medicine hospitalists who do some critical care, but that's not kind of their specialty. So being able to have access to someone with critical care training and walking them through plan of care, with an intubated patient or something like that, it's been invaluable for them. And I think it's pretty clear if they're able to talk with someone and say, okay, does this patient need to stay or go? Well, they can stay. Here's the care plan. If this arises, talk to us again and we'll look at transferring, versus not really knowing whether we should keep them or send them. I think they kind of get put in this awkward situation, and I would think that's stressful for them.
Oh, for sure. It's interesting you bring up that point. We've seen that, particularly in hospitals your size, where, for example, one of the challenges a hospital was having is their ICU census was pretty low, and they did not have critical care available. And the hospitalist team there was a team of about 14 providers, and out of the 14 providers, probably eight or nine of them were essentially very uncomfortable with any sort of critical care types of things. And they really, at the end of the day, weren't big fans of taking care of ICU level patients. They wanted to stick more on the medicine floor or maybe progressive floor, and they just didn't want to do ICU. And so the challenge was you can either try and force them to do it, which is not an ideal situation to put a provider in, right? Or you can try and augment that with pulmonary critical care or critical care services where they're still the attending in the ICU, but they have that pulmonary critical care physician who can really manage the vent settings, ongoing gases, hemodynamics, pressors, vasopressor strategies, and those sorts of things, and be a resource for them and other sepsis related issues. I mean, all kinds of different things. And if you profile the whole hospitalist group, you'll have a couple they just love doing it. That's their wheelhouse. They love it, that they're all in. They need little support from the pulmonary team unless all things are breaking loose. And then others, they rely on them pretty heavily. And the beauty of it is you can kind of leverage that however you need to, but you keep your the ICU census where it needs to be. Your case mix stays up, and you. The big thing is you retain your team versus having people leave because they don't have that resource available and they feel that pressure, to admit these folks to the ICU. So I can't agree more. I think it's really helps to augment the overall physician practice and physician satisfaction overall in terms of their quality of life and job satisfaction. You mentioned that a couple of times. You're the largest hospital in the region over there, and we've been working with several hospitals. One of the things you mentioned before our conversation, shortly after or I shouldn't say after the pandemic, but as the pandemic was winding down, and my analogy of pushing a boulder up the hill, then all of a sudden it's over the hill. Now it's rolling down. We're just trying to catch it, but one of the things that we're starting to hear from a lot of hospitals your size, or kind of that 120 to 150, 180, 200 bed range, believe it or not, there's a lot of hospitals out there that have done little in the way of virtual care, and others that have dabbled in it, others that have 5 or 6 different various vendors, providers trying to get into this space or have been in the space, and there's some frustration with that. But what piece of advice would you give a hospital similar to your size that's out there? They may be rural, they may be somewhat urban-ish or suburban-ish, but nonetheless about your size, and they're kind of pondering these types of things, and they have, in discussions with the med staff, they have variability, of course, in the med staff and their opinions of across all these types of services. But what would you say to a group of CEOs that are pondering these types of services? What advice would you give them?
That's a good question. I think there's always some low-hanging fruit at first, and I would try to figure out, okay, what's going to give us the we're at a point where I feel like we've done virtual care so well that we could maybe bring in something that is maybe a little unique, but our medical staff has bought into it so well that they would be willing to try it, and it wouldn't be a big deal. We've seen it be successful in other areas. So you're going to have to find those areas where it will clearly be successful. And probably the 2 areas that I would say seem to be successful every time would be your stroke neurology and then your pulmonology. And reason being is, even like stroke neurology, for example, most places that have implemented a telemedicine program actually saw their door to TPA time improve with virtual care versus having people come on site. And because it still takes time to get dressed, jump in your car, and get to the hospital where you can Zoom someone in, neurologist can jump on in their pajamas and make the decision, and you can move forward. So that's an area where you'll find easy success, fairly fast. Pulmonology as well. If you're not a hospital that has 3 pulmonologists or 24/7 coverage, it's one that'll have a great success early on. So I think you look at a service and you say, okay, where can we really see some actualized benefit? And it's really clear right away. And once you get that first program going, the second one becomes easier, the third one becomes easier, and whatnot. Our nephrology program that we have, prior to partnering with Teledyne on nephrology coverage, we would have a nephrologist who would be here, do his 10 days of call, and when he wasn't on call, if we had a inpatient dialysis patient, we would have to transfer him out, if there wasn't going to be coverage for that. So you could clearly see that benefit early on. So I would just say look for low-hanging fruit, which if you could look at if you have some high locums expense somewhere that could be done virtually, that would be a good spot. If you have an area where you have coverage some of the time but not all the time, that would be a spot that I would go to as well. And I think that if just really analyze the programs that you need or that you'd like, and take the ones where you can see the greatest benefit the fastest. And once you get a program going, it becomes a lot easier to get that second, third, and fourth one going.
For sure. But I love everything that you said there, Ivan, and all is makes 100% sense. And those are some of my most favorite conversations I have with hospitals, is working around those types of strategies and what are they thinking, what are their needs, and trying to help flush out what makes the most sense. And certainly Man, the acute neurostroke programs have been a raging success really everywhere we've gone with those. The neuro coverage on top of the stroke coverage is helpful. The inpatient stroke and neuro coverage is so helpful, and just facilitating that across the organization has been helpful. And even facilitating the outpatient coverage on the neurology side has really kept a significant amount of patients in a lot of hospitals. Similar to your size and smaller, and in some cases significantly larger. And to your point, even in the health system in Lincoln, where they had, to give you an example, where we started covering virtually, even in the huge tertiary center. To your point, Ivan, the door to needle times were so much faster with the virtual coverage than they were the boots on the ground. Not just, again, if you're in the middle of seeing a patient on the 6th floor and you got to get down to ED
right across campus.
Yeah, go across campuses. It's difficult. Or in the middle of the night, trying to get through the big city to get to an area, it's a challenge. So they definitely do work, and the ROI is substantial across all those programs. So they have been dramatically successful, and I want to say that you and I have had so many conversations over the years, in fact, even recently, related to what does it look like for Great Plains Health moving forward in the future, and what are you thinking in terms of downstream strategies? We've talked a lot about ancillary services on top of what we've already accomplished there in terms of the other subspecialty services and other various programs. But what do you see for Great Plains Health in terms of areas that you're considering and focusing on moving forward?
Yeah, it's been interesting as we've kind of looked at what's out there. We have most of the services that can be done virtually implemented. There are a few that we're staffed well with right now. We're lucky. We have a pretty well-staffed group of psychiatrists, so we haven't really had to do a lot of telehealth with behavioral health, where I know even,
which is amazing, by the way.
I mean, there's hospitals a lot bigger than us that can't staff it and do a lot with virtual health, so with virtual care. So we've been great there. We've seen some success with hospitals our size with hospitalist services, and we've been pretty well staffed there. So I see those two as, if we ever find ourselves in a situation with our medical staff, I see those as two areas that we could potentially implement in the future. And it's been kind of fun to take on some services that were unique. I think we were the first to do telepathology in our state, and it's you look at they've been doing it with radiology forever, and some of the ability to manage a microscope virtually has really improved. So that's been a fun service. I think from here, we're probably going to have to look a little bit more at the technology and integrating everything. We have these wonderful, we call them telemedicine robots, but they're really high-end carts where you can do a full physical examination and take care of a patient with those carts. As we have more and more services, we need to figure out how we can maybe get that technology in each room, and so we don't have some of the delays with getting equipment at the bedside for. It works out pretty well, but sometimes when you have 2 or 3 specialties on telemedicine call, there's a little bit of a traffic jam now and again. So I think our platform is going to have to be something that we'll address, and then I think just keep pushing it with the services. There's like I said, there's a couple we just mentioned that we could implement at some point, and just really being open to, how we can, be on the forefront of bringing access to this western part of Nebraska.
Yeah, I can't agree more, and I have had calls from some of the providers over the years saying, Shane, the carts are too busy at Great Plains. I can't get in, man. You got to tell the nephrologist not to take so long with his exam, or vice versa. It's kind of funny that way. And by the way, I love those calls when the carts are too busy to handle the incoming physician traffic is a good problem.
This is a good problem.
It is. But I agree. I can't agree more, Ivan. We're seeing that a lot in terms of the other ancillary services, whether it's virtual nursing, patient sitting, those types of things. And you start adding those ancillary ancillary services at some point on top of a busy program already, the traffic jams will only get worse. And so, sort of a civil engineering strategy, right? Now you're going to route all that traffic to get to the rooms at the appropriate time, so that there's no delays. But certainly agree. We've had a lot of those conversations, and also, trying to stack the technology in a way that streamlines that experience, so there's not a bunch of disparity across how you're trying to manage that. You did bring up a point on hospitalist and of course the pathology program. I would say, prior to the pandemic, by and large, our hospitalist activities, which is significant, was primarily in the smaller rural hospitals, more the critical access hospital size. But post-pandemic, we're doing a substantial amount of hospitalist work in hospitals your size and even larger, and various models, of course. But nonetheless, similarly, there's been some challenges with continuity issues across some of these organizations, and there again, the virtual strategy can play a role. And there's so many different variables that we can plug in and adjust to help with those programs, that they're very helpful. The pathology program was very interesting. Ivan called. I was at a conference. I was speaking at a conference. He called me out of the blue, and he says, "Hey, I got a question for you. What do you think about? Do you have telepathology?" I said, Ivan, we don't. I said, maybe we should. I don't know. Let's do some digging. And that started a process which really evolved. And at the time, you were trying to recruit, if I recall correctly, you're trying to recruit a pathologist, right?
Correct. Yeah.
And we, long story short, we put this program together, and it ended up working so well. You kind of said, "Well, I think we're good," from where you were at, right?
Yeah, it worked out well. We recruited a pathologist here, and a general pathologist, and I think one of the challenges is we really do still need some boots on the ground pathology, and we probably, maybe we could get to 3, but we probably have the need for 2, and just like with anything in medicine, things have become very subspecial. People have kind of their specialty and their subspecialty, and so. Now, we had been researching before talking to Shane. We had been researching some of the different technology that was out there, and there's actually 3 or 4 different telepathology, digital pathology products out there. And so we kind of found a product, and the beauty about having a good relationship with Teledyne is they're open to new things as well, and so. It was kind of like, hey, who's your pathology group that covers you? Let's have a discussion. And that pathology group could kind of see the vision. They were open to it. It's Pathology Medical Services out there in Lincoln, and we did some demos with the equipment. They said it was great, and so we now have the vast majority of the stuff we're able to take care of here with our pathologist. But if she says, hey, I really would like to talk to someone who is specialized in cytology to kind of take a look at this. And so, our pathologist can, call up one of the subspecialists. They'll look at a slide together, review their thoughts and discussions, and then basically our pathologist that's not on an island now. They have other colleagues to kind of work with and through cases. The other thing that you'll find is with us doing, neurosurgery and a lot of other different cases that we do, every once in a while you'll need a frozen section. It's not very common anymore. It's become less common, but it is we need to have the ability to do it. So our pathologist is on call, maybe 10 days a month, and it might be once or twice a year they get called in for this, but they want to leave town, and so now we have the ability to. We have our pathology assistant that takes call as well, and she can come in when there is a frozen section, process it, but gets the pathologist online. They'll take a look at it and kind of give them instructions on how to move forward. So we're able to do frozen sections virtually while not having a pathologist here. We have one in Lincoln, Nebraska that's able to guide and direct the surgeon. So now again, this happens very rarely, but when you need it, you need it. And so having that ability is just important for us to keep our services going out this direction.
Yeah, absolutely. Yeah, absolutely. So it's always a pleasure to talk with you, Ivan. I always enjoy stopping out and chatting with you and the team out there. It's always a great team and a pleasant experience, and I appreciate just the the back and forth that we always have when we get together and discuss all the fun stuff that's cooking. And Ivan mentioned, when he calls me the folks that work with me definitely know that the change is coming. It's just how we're going to do things. We're gonna do new things, change things, innovate. And it's always great to have partners like you that want to join in and help make those things successful. Because again, I've said this 1,000 times that these programs are only success. This is a two-way street. You got to have a partner and an organization that wants to make this happen and put in the effort and the quality and the energy into the program. You got to have a great partner that is right alongside you doing the same thing on the other end, and they really go very well. And so I can't thank you enough for you being a partner of ours for over 7 years, and B, the fantastic your work that you're doing out in rural Nebraska and really covering that whole Great Plains corridor out there in western central Nebraska. Doing a fantastic job. The patients love you. The city thanks you. I thank you. And I really do appreciate you spending some time with us today, Ivan. It's been a pleasure to talk with you, and I can't thank you enough for your time.
Yeah, likewise. We've been great partners, and I think that we talk about telemedicine like it's some different subset of medicine. And I think the reality is that telemedicine, it's not something that's out there. It's not something that's fringe anymore. Telemedicine is medicine, and really you need to just know the appropriate way and the appropriate function to provide the medicine, and telemedicine needs to be integrated in my opinion, in every hospital and health system in the country now, because it's part of medicine.
Yeah, I can't agree more. And you're speaking my tune, Ivan. I tell you what, you need to go on the road with me here and there. That's what we need to do. But hey, again, Ivan, really appreciate your time today, and I thank you very much for all that you do for all your patients out there and your team. Team loves you, patients love you, so it's a great organization. So we're honored to have you as a partner.
Thank you. It's been fun.
We would like to thank you for joining us today. Our promise to you, the listener, you will be inspired or at a minimum find value in the information shared in this podcast. Please offer a comment or offer feedback so that we can improve this podcast and better meet your needs. Please remember to share this podcast with others that you feel may get value out of this by listening. And it's always helpful to subscribe to the podcast channel so that you're aware of future episodes and releases. In addition, if there is a rural health topic you would like to have covered on this podcast, please leave us a comment, or you can send an email to pulse@teledymehealth.com. That's pulse@TELEDIGMhealth.com. For more information or general inquiries, please visit teledymehealth.com.